diaphysis. What we use for this treatment? We will use one ring, distal ring of the femur here. We use 1/5 of 8. We put it and distillate of the fracture. In another one, 5 of 8, we put proximal part of the fracture. And I will show you how we will connect it and how we reduce the fracture. Okay. We start usually with the patient in supine position, and the patient should be put in a traction. Skeletal traction should be done on the proximal tibia, flexed knee. In this way, the fracture, it will be better realigned. After that, what we do, we put the distal wire of the femur, and we will do it for simplifying our surgery. We will do it, the first wire, we put not parallel of the knee joint, like I said, for the tibia, but we should put it perpendicular of the diaphysis of the femur. And practically, if you remember the inclination of the angle, the knee joint form the angle between knee joint line and the distal diaphysis of the femur 7 degrees. It means should be inclined at 7 degrees of the joint, or better again, you look to the fluoroscopy and you put it exactly perpendicular to the diaphysis, like this. It's better to put this wire practically, one second, in the horizontal plane, like a patient stay, like you see I do this, because in this way the knee motion is easier if you put the wire in this frontal plane position. It block it less muscle than normally. What we do now, we put the ring, but for simplify our job, we may connect them directly. One second. Usually I prefer always use half rings. In the way you may always disattach them, open them, and put like this, okay? Keep it, please. Okay. For simplifying our job, we connected them directly with the rods. I chose in this way 150 millimeters rod. Okay, put here. No, better maybe start here. We should find connection. Okay. This diameter of these two rods, two rings, the same. It's only for simplifying, but usually in the middle shaft there's much more soft tissue. Sometimes you need a little bit bigger 5/8. What I do, I put one ring, one rod, and I put another one near of this. 1, 2, 3, 4, and I calculate, because this way I may achieve easier alignment between the rings. They will be self-adjusted. Oops. Between them. like this, and this. Okay, we tied them. This distance will be stable, like two rings on the tibia. Between them, they are connected strongly. Okay. When we put two rods, now it's easy to put another one down, because in this way, two rings now are parallel, because this rod helps us to put them parallel. I put another one again, maybe distal, and this way the rings self-adjusted. Okay. Mm-hmm. Okay, thank you. Okay, perfect. And now, like you see, we put this system. It is a distal system. The bond is not that. Close. Oh, shit. See? Okay, okay, that's enough. Yeah, this rod disturbs me because this is not the same position situation like in operation room, because in operation room I should have superficial down, free for movement. Here I don't have superficial. Okay. Ready for now only 3 rods, 2 rods. And what we do, we should do, we attach the distal wire here. Obviously here, anteriorly it will be less distance than posteriorly for the muscle. We put always this bolt at the level of patella. We design patella and we put this bolt for better orientation of this. Remember, we talked about rotational deformity, and remember then when you do the patient in the traction table, and you should, really important thing, control the rotational deformity. You should see the knee joint position in frontal plane, and you should see the hip joint in the way you orient it of the small trochanter. It should be just a little bit visible, and not if you see too much small trochanter, it means it's external rotation. If you don't see the small trochanter, it means it is internal rotation. And you adjust rotation just in the operation room, because to do it later is much more difficult. But you know better than me who put the nails on the femur and knows how to do this. Okay. Now we put this wire. I tied this. Good. Okay, and with tension from this side. Okay. When we put this wire, you understand, if there's a wire exactly perpendicular to the diaphysis, and you put the wire on the ring, your system, your frame just became parallel to the distal shaft of the femur, okay? We realign it. Another thing that we should do, we should now see if there is we should prevent forming the varus and valgus deformity. What you do now, it's just a little bit now, because it touched it here, and not comfortable, okay? Tight it, okay. Perfect, okay. And what we do now, we may stabilize again this ring, but in this case now, usually nowadays I don't use too much wire in the femur. Usually we use much more half pin, and we use in this case the half pin 2. Now we use half pin, maybe you have here, long one. Mm-hmm. Okay, what I do here, I put one whole cube, this one whole cube, okay, and I attach all this 5 of 8, I need a small bolt, yes, this one. At the half pin, here in the middle, I put it a little bit more posterior, or exactly in the frontal plane for manipulation. Che ci vuole? Prenderla piccola, no? Because no, lui sporge ancora. Facciamo così. We use the bolt with the nut because oh, okay. We do like this. Okay. In the diaphysis, it's better to do pre-drilling, to put the drilling, and after that they put the half pin, because sometimes if the diaphysis is too strong, it's really difficult to penetrate it if it's self-penetrating half pin. It depends on half pin. It's good quality, it may do it, but if you do pre-drilling, it's better on the diaphysis. Okay, I put, now like you see, I keep my frame exactly perpendicular to the diaphysis, and the level of these rings is difficult to control. Better you see it in fluoroscopy. But the control of the procurvatum and recurvatum not always easy. In any case, we do it by eyes, like this. Okay. We tight this half pin, but this half pin may become reducing instrument for reduce the fracture. But in any case, if you control it in the fluoroscopy and you put exactly perpendicular to the bone this half pin, it will be easy to adjust varus valgus deformity, because you see it in the realignment when you put this system. Much more difficult to control the recurvatum and procurvatum. For this reason, I show you how we treat this situation. Now, what I do, now I should start creating proximal part for reducing. But like I know that I may have the procurvatum deformity, I want to create just the hinges that permits me to do the correction of the deformity. What I do, I put one male here, or maybe yes, like this. Another male I put down. It should be positioned at the level of the fracture. We do it similar. Okay, after that for connection, I use this rod, normal rod, and I attach here female post. Preparo un altro. No, questa o tanta. Okay, I attach female post to this rod. And this way we create the connection, but connection with a hinge. One. Okay, another one. Another one down, bolt. Create another hinge. A really important thing, like I said to you before, that this hinge should be exactly at the level of the fracture. Because if we manipulate the fracture, we should put it exactly in this level. Not up, not down, because if you do angulation, you may achieve translation. If this hinge exactly at the level of the fracture, like a cora, you may do correction of the deformity. Okay, we put two rods. Now the system is not so stable, but it's only for building frame. And we put now the proximal half of 8. Again, yeah, we have in Italy another system. We have a smaller arch, not only 5/8, but smaller, because for the proximal part of the femur, it's better to use this small arch with many holes, because it's much more comfortable for the patient. Better use this one, okay? In this construction we do like this. I leave the rods long, because in this way I may do lengthening of the level of the fracture or correction of the deformity. Like I explained, I'll show you how we'll do this later. Okay. We connect them. What we do now we should fix the proximal part of the femur. In here, we use the cubes. This may be 2 holes cube, 3 holes cube. It depends of how you want to distribute it. This is a cube. You attach it here. Again, like I said, anatomically, it is better to put the wire half pin just a little bit posterior. In this way, you don't penetrate the quadriceps muscle. You should cut a little bit fascia, and after that, put in the wire. Questo non va. Troppo lungo, sì, mettiamo piccolino. Okay. I put this third hole of this. Obviously here you should again control on the fluoroscopy. You put your half pin, it should be exactly perpendicular to the axis of the femur. You control if it is inclined, it's no good because it means after you tight this half pin, the bone will be displaced or angulated. If it's perpendicular, it's the same like this half pin, this wire, the femur will be good realigned. There is no varus or valgus deformity. Like this. Always in the diaphysis we do pre-drilling. The soft bone is really soft, we don't need this. Okay, fix it. Okay, we fix small bolt or medium bolt here. Okay, after that we may do another half pin, minimum 2 of them, it should be done. Maybe small bolt again if you have. This is short. Do you have again? Yes. Okay. I put 2-hole post, 2-hole cube. Maybe we incline it a little bit more. Depends on the soft tissue, how we want to distribute, and now we'll do again, controlling fluoroscopy, put it not so near of the fracture, but not so far, and the way it's stable. Touch it. Do we have a small bolt? Okay, the proximal system should be absolutely perpendicular and stable. We don't do the manipulation of the proximal part because it's like a base of manipulation with distal system. Okay. 2 half pin is quite enough, but always better to have one more. Maybe we may put it later and for stabilization. Now, this system it's not so stable, but this system permits us to remove the plate and manipulate with the fracture. Sì. Okay. Meanwhile, I prepare another rod for connection because, like you see, this is only 2 rods. What I do now, I put one more in the lateral position here. The same holes, symmetrical holes. Okay, the same position as sagittal plane, like the two previous rows, and we put here female. Yes, this nurses prepare for you during surgery. Okay, and I connect it. I put the same position. Okay, in this way we have minimum 3 rods, and they're stable, and we manipulate with them. Now, the patient again, it's skeletal traction because it's easy for us, because for better realignment. It's difficult to understand if there is procurvatum, recurvatum. You may see it in lateral view and control it. Now what we may do here, like you see, this system now permits us to do the adjustment, which kind of the adjustment we want to do. For example, now I see that my bone, it's not penetrated enough. We do more, because don't keep so good the bone. Okay, again? Okay, thank you. Perfect. Well, you see now, if there is a displacement, our distal fragment goes medially, and we have angulation and translation of the fragments like this. What I do here, I manipulate with this half pin. Obviously, we don't have a good instrument. There should be instrument that keep the half pin. And what I do, I manipulate with this half pin in the hand, and like you see, I may do the translation up and down. And the same, we may do this half pin manipulation for the achieving translation. I rotate this half pin like this on the cube, And you don't see it probably in lateral view. Now we try to demonstrate you. Like you see, with this half pin, I may do this kind of manipulation, up and down of fragment, and I reduce it, okay, like this. Because you see, I manipulate this half pin, like this, with a cube, and my bond shifting, because distal wire is elastic enough, it permits me to do all this adjustment. I did this, I do the same. In this position, I push up and this half pin, and I adjust it. When I see the position of the bone, it's good for me. I like it. What I do, I fixed the half pin in a cube in the beginning. In the way there is no more translation. And the second that I do, I fix the cube on this system. And this way, I reduce the translation. Just a little bit more. Okay, I reduce this. Now it's just, with this small system, I adjust my fracture. Obviously it's not stable frame, I should do more. I should put another half pin distal part. We use, again, 2-hole cube maybe. Do you have another half pin? Okay. And this half pin should be put in on the from posterior to anterior, from lateral to medial, in the way that you achieve a good crossing half pin, but they don't disturb you for flexing the knee. Goes like this. Not easy because sometimes it's shifting. Okay. Now it became much more stable. And the distal system, not more elastic like before. Okay. Fixed all of them. It became stronger. I put third rod here where I have a space here to connect them parallel to another rods here. Stabilize it. Okay. Third, if you always better to have in the system to have 4 rods. Now we have 3. We put another one here. Because 3 rods not enough. Always 4. Here. Okay? And like you see now, this system, proximal distal system is so strong. If your patient is heavy or you want to do more stability, you may put another half pin from the medial part. You put the cube again here, or more proximal, and you put the medial wire from posterior medial to anterior lateral. We don't put it because we don't need to, we save time. But what's happening again, I want to show you, because like I explained you, in the EP view, it's a little bit movement. It was easy to adjust the position of the bone. Then you control varus valgus. In lateral view, it's much more difficult because it's difficult to do the X-ray, it's difficult to see all the bone. For this reason, I put here the hinges. And I prepare them oppositely because I may find a situation when I will have maybe, oh yeah, I'll show you if there is a procurvatum deformity, okay? This hinge, lateral one, this hinge, where is it? No. Okay, I can show you. Because, this is a camera, which one? This, okay, no, use this, okay. This hinge, no. Which camera use, this?
Top? No, top.
Top.
Okay, let's leave top.
Okay, you see this hinge at the level of the bone. This permits me correction procurvatum or recurvatum. Okay, what I do, I release anterior or posterior. And you see, we have a procurvatum deformity. Now a little bit not stable, but procurvatum deformity. What I do here for correction of procurvatum, I short the anterior rod, I lengthen posterior, I adjust it. I change the position. Yes, and now it's realigned. There is no more procurvatum. Okay? If it is vice versa, for example, it is a recurvatum. Like this. Okay, now it's recurvatum deformity, like you see here. Probably you see from, this is recurvatum, like this. Oh, you see the deformity. And what we do in this situation, we do again. We lengthen the anterior part, we shorten the posterior, and we adjust our deformity completely in lateral view. Okay. This hinge is really useful because if you put the straight rod, you can do this movement. It will be difficult. If you prepare it in advance, you may do all this adjustment much easier during surgery. Obviously now this frame, it's not so stable again. Like I said, you may put again this another half pin more proximal here. The level maybe supratrochanteric area. We may put another cube, or if you will have it, you will put a small arch here, or there is a system for putting the inclined half pin, like this one. This is a cube. You may do angulation. You put like this. And rotate it. And after that you may only, I don't put the half pin, but I only show you how it may be done. If you want, maybe I put, or like this in any case. Okay. We put like this for more stability. And this will block it proximal part, and the distal part, like I said, one half pin, one wire. We may put another one wire on another half pin here. In the majority of the cases, we use a half pin for the femur because much more comfortable for the patient. I don't put the half wire on the middle because in this way you block the quadriceps, and it's not so comfortable for the patient, and they lose the movement of the knee. Okay? This is universal system. If you want to do it more complicated, it may be done here on this level by planar hinges, in the way you may correct deformity procurvatum, but in any case, varus, you may adjust it much easier and much more difficult, like I said, the procurvatum deformity. Okay, we finished this workshop because we don't have too much time. Any question?
We are 10 minutes behind time. 10 minutes for a question. We start